comes out of the bag with the mask on. I recommend taking the mask off when you're setting it. It comes with this red cap for a reason, which may or may not be in place. Put the red cap on, turn your flow up. I would do probably 10 to 12 on a term child. And you'll notice there's no PEEP right now, right? Okay. So you can turn your PEEP up with flow until you actually see how the needle's coming up. Okay, so right there I'm at a PEEP of about 6 or 7. So that's just by dialing this up, okay? And then, and this does turn so you can set it, okay? If things are not ergonomically for you. Okay, I've got, hang on, let me get this cap back on. Okay, I've got a PEEP of about 7 right now. Now I can set my PIP. So this is PIP, this is PEEP. You tighten it down for higher PEEP, you back it off for less PEEP. If you set your T-piece between green and yellow, right about on the line, generally, and then put your finger over this, you're gonna get about 20 to 22 of PIP every time, okay? You may have to adjust the PIP up a little or the PIP down a little. These are not consistent, they're very rudimentary, but they work well. Okay, so right now I've got a PIP of about 21 and a PEEP of about 7. Okay, there's a PEEP of 5 and a PIP of 21, and that's right in the NRP guidelines. Okay, so then once you have it set, then transition to your mask. Have this, if you have the time, have this set up flowing with your pressure set, ready to go, just laying here. And then when the baby hits the table, stimulate, dry. Is the baby vigorous, not vigorous? If they're not vigorous, dry, stimulate, look for spontaneous effort. If there's no spontaneous effort, go straight to PPV. If there's spontaneous effort, then you can consider giving them CPAP with room air, and then go by your NRP chart and watch your saturations. It takes a while for these guys to transition, up to 10 minutes before you're gonna get saturations that you're accustomed to seeing on any other patient, okay? When you're ventilating these guys, and if you have to go to PPV, and you start delivering some breaths, you can see like stomach rise more there than chest rise. There's a little chest rise, okay? If you have to start ventilating these guys, then your brain has to go straight to, we gotta drop some kind of oral tube or nasal tube right away. Their stomach is far more compliant than their lungs, and it's gonna follow the path of least resistance every time.
Would you sacrifice a little time of ventilation to put in that too?
Yes,
You would?
I would, because it's going to pay dividends in the long run. As you start to ventilate, the more you fill up that stomach, the less effective.
Unclamp the umbilical line and then just let it come out.
Yeah, there you go. There you go. Well, that'll make room, but that'll make room.
Through the hepatic vein.
Because the more you inflate the stomach, the less beneficial your ventilation effort is going to be. It's just going to get worse and worse and worse. Drop the OG, start ventilating. Give it a chance to work also. These are brand new lungs. They've never been filled with air before, ever. So as you recruit those alveoli and you actually start to get some functional reserve capacity, getting air in there, you're going to see the chest start to respond more and more with your PIPs. If you throw this on here and you give 3 breaths and you see no chest rise, that's not unusual. You may not see a chest rise. So 3-6 breaths before you start seeing some adequate chest rise. And don't be hasty. Don't think, oh my God, I gotta crank up my PIP. This is a bad habit, okay? Crank up your PIP only after you have chest rise, you know you're ventilating the child, you got lung sounds, and then if you're still not getting the response out of your heart rate and your sats you want, then maybe consider turning up your PIP by about 2 at a time.
You know your ventilations are adequate if your heart rate's going up.
Yeah. And your respiratory rate, breathe 2, 3, 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 breathe 2, 3. Okay? Make sense?
Mm-hmm.
Okay.